This talk is about looking at the outlier patient in total knee arthroplasty. Essentially, does recreating the constitutional alignment give you a better outcome? This is a series of my own patients that I have done mechanical alignment on, and those that have had alternate or functional alignment, where they have been left outside of the traditional 3 degrees of varus or valgus, which is considered neutral, and compared the outcomes of these patients over time. So just going through some important facts about knee replacement. And it is important to note that we have a very, very good operation. The numbers are increasing, at least in Australia, 5% per annum. I think we are doing very well, but in fact, we have a dissatisfaction rate of 20%. And a revision traditionally has had a double the dissatisfaction rate of 40%. One of the biggest problems that we face is that our assessment tools are at best very average. And do we have a surgical technique that could potentially solve this dissatisfaction problem? Maybe. And currently, the large published studies show no difference between mechanical and alternate alignment or functional alignment. So if you look at this landmark paper that was published looking at constitutional alignment by Bellamans, you can see there's a graph that looks at these 70% of patients lie between -3 to +3, which is what we consider a neutral alignment, either side of 0, 0 obviously being a straight knee. However, there's a significant proportion of patients that lie outside of -3, meaning more varus than -3. And there's a small proportion of people that are actually valgus of outside of 3 degrees, about 5%. So you can see 70% of patients are what we consider straight, 25% are varus outliers, and 5% are valgus outliers. So what does this all mean? So if you look at the current surgical techniques that we have, the mechanical and alternate alignment techniques, and if you take an overlapping graph or a chart over them, and we know that when we do the surgery, 70% of people are in ±3 degrees. So there'll be a significant overlap between the mechanically aligned post-surgical patients and the alternate or the functional aligned post-surgical patients. But in both groups, there'll be that small percent of patients that are outliers. So there's about 30% of patients that you would do in a mechanical would have outlier anatomy, and 30%, according to Bellamans, would have an outlier anatomy for the alternate alignment as well. So if you looked at the outlier patient versus the outlier patients in each group, this is where I think the efficacy or the effect of alternate alignment techniques come into play. Now, essentially, the patients we are looking at are in this range. So those that are outside of +3 of valgus and -3 of varus. So these are the patients that I'm trying to look at in my patient cohorts. So as you can see that this outlier was in the mechanical. So when you do a mechanical aligned knee, that outlier patient gets dragged back into being straight or ±3 degrees. Whereas in the concept of alternate alignment or functional alignment, you leave these patients in their outlier constitutional alignment that could be potentially outside of ±3 degrees. So graphically, when you look at the traditional papers, this is a illustration or a cartoon drawn by a PHO of mine when I told him my concept of what I was thinking. It's like you have a swimming pool, and if someone were to pee in a swimming pool, it's very difficult to measure the difference in the water height. However, if you took a bucket out of this pool and you peed in the bucket, you would potentially see the difference in the water height in a bucket. Essentially, the small number of patients that are outlier patients may see the benefit of the actual technique, not necessarily the full group of patients. As I said, 70% of patients are plus or minus 3 anyways. So the question is, how do we predict these outliers? So it's not that difficult. You do preoperative templating. And let's take this patient, for example. You've got a HKA of minus 13, minus being varus. If you look at the mechanical lateral distal femoral angle, this patient in fact has a varus distal femoral angle of -1. If you look at the medial proximal tibial angle, it's a -5 degree angle. What does that mean? If you look at this patient's constitutional alignment, and if you were to correct this patient for the pseudo-laxity on the medial side, you would still have a varus knee of 6 degrees. This patient was never straight. So the bony anatomy, the articular bony anatomy is dictating that this patient has a varus alignment of 6 degrees. Now, to get this patient straight, you would have to release ligaments. And that's the mechanical alignment philosophy. Now, to validate this concept, this algorithm or this arithmetic formula of mechanical lateral distal femoral angle plus mechanical proximal tibial angle equals constitutional alignment. So I took 38 patients from my database, and we looked at to see if this alignment of the X-ray preoperative templating correlated well with the post-op stress alignment on navigation intraoperative. So here's a regression analysis that we did on this cohort of patients, and we found that the R value was 0.58, which is quite a significant correlation between this arithmetic formula that, mechanical lateral femoral angle plus mechanical proximal tibial angle is equal to constitutional alignment. So we can predict those patients that are constitutional outliers by this simple formula. Now, if you were to compare these patients with the mechanical cohort outlier versus anatomical cohort outliers, what I did was I took all patients who started the disease alignment of 10 degrees plus, so 0.95 degrees minus. So this is all varus patients. And we assumed that these patients were constitutional outliers of greater than 3 degrees. Unfortunately, in those days when I first started navigating this before 2016, I did not have the preoperative templating techniques, and I did not measure, or I did measure, but I did not keep a database of the angular cuts of the distal femur and the proximal tibia. So there's an assumption being made here. All patients had post-op alignment that were between plus or minus 3 degrees. So all these patients started life outside of 10, and they were brought back into plus or minus 3 degrees. We compared the probably 6 weeks, 6 months, 12 months, and 24 months. And then for the anatomic outliers, all patients had a proximal tibial resection of more than minus 3 degrees. So their proximal tibia was resected outside of 3 degrees. All patients had a mechanical proximal tibial angle measured and resection data collected. All patients had post-op alignment restored outside of 3 degrees. So they were more in varus. On NAV and on X-ray. So essentially they were left in their constitutional outlier alignment. And again, we compared their proms as well. So again, just to go through the validation process, we looked at the tibial resection angle versus the templated angle. 37 patients were included in this set, and the range was plus 3.5 to 6.5. And as you can see, about 60% of patients were between 0.5 degree of the templated, and if you look at 100% of patients were between 2 degrees of what was templated. Again, the correlation, the regression analysis showed an R value of 0.5, which is pretty good. The next correlation we did was to look at the pre-op stress varus to post-op neutral in extension. So what that means is the surgical technique that we utilize when we stress the knee out of its disease varus alignment, and we say, what is the degree of alignment that we are chasing? And that's the post-op neutral. So we don't stress the knee after it's been replaced. 36 patients included in these data sets. Of the +3 degree difference, the angles were 4 and 5 degrees. So you can see over here, almost 70% or 80% of patients were between 0 and 1 degree. So again, the correlation is pretty strong and it sits as 0.8. The last validation we did was to look at the post-op neutral alignment, the correlation with the post-op X-ray. And again, the correlation was pretty reasonable. So what we actually thought we were aiming for is approximately what we got in post-op long leg alignments. So here is the group of patients that I looked at the PROMs on. There were 60 patients in the mechanical alignment and 45 patients in the alternative functional alignment. The demographic data was very simple. The only difference is that we had all the patients in the mechanical alignment were triathlon CR, and when I started doing alternative alignment, I used a few different prostheses, including the Apex and the Attune CR knee as well. So let's look at the womec score, the overall womec score. This is just in a graph representation, just to show that there was a difference. So they all started life at a very similar between mechanical and alternate alignment. And as we went through at the 6-month mark, we could see that the alternate alignment were doing a lot better. But because the study was done in 2017, mid-18, I had very small numbers at the 2-year mark, and the results were similar. So I'm in the process of updating this study with more outcome scores at the 2 to 3-year mark. And if you look again over here, this is a functional subscore, looking at rising from sitting, descending, stairs, standing in and out of a car and out of a toilet. And you can see the difference is even larger for the overall, more the functional outcome. Again, now we're looking at the pain subscore. So you can see that patients are pain-free a lot earlier compared to the mechanical alignment, and they continue to be more pain-free throughout the whole lifespan of the joint, up to 2 years. When again, small numbers over here, when I have more patients included, I may be able to see a bigger difference at this point. And over here, we have the Knee Society score. It didn't show a major difference. However, there is there is a graph difference to see that they seem to be showing a trend better towards the alternate alignment. So the thoughts on this paper, 80% of patients will do whichever technique we do, because their alignment is between plus or minus 3 degrees. 20% need careful attention to native anatomy. Long leg x-rays can predict constitutional alignment. Templated proximal tibial cut is an accurate guide to intra-op resection angle. Navigated alternate alignment surgical technique delivers predictable intra-op execution of preoperative plan. And PROMS data provides reassurance that clinical outcome is not compromised if tibia is resected outside of 3 degrees. In conclusion, the alignment technique outside of mechanical appears to have best application amongst the outlier patients. Outlier patients seems to do better with restoration of constitutional alignment. At 2 years, no early failures were recorded due to excessive tibia varus. Navigation is the key to execution of minute angular variation. I hope that this presentation has been of help in understanding where possibly the non-mechanical surgical techniques has its best application. And as I add more data to my data set, I suppose I'll be able to show more clear difference between the outlier patients. Thanking you.